Hello and welcome. I'm Associate Professor Michael Woodward, a specialist geriatrician, and I'm going to be your host for this Souvenaid case study mini podcast. Before we begin, I'd like to note that this case study has been fully anonymised to protect patient privacy, and consent was obtained to share the details for educational purposes. Whilst this is just one individual case, it offers valuable insights into the type of patient who may benefit from Souvenaid as part of a non-pharmacological approach to nutritionally support Alzheimer's disease. Souvenaid is a food for special medical purposes and must be used under medical supervision. This podcast is for healthcare professionals only. Now, let's begin. Here is the background. On presentation, Eric was 81, had been married 56 years, had 3 children, and he was a retired IT professional who helped manage the first computer for his company. He was independent, driving, and using technology confidently. His medical history included atrial fibrillation with ablation, elevated cholesterol, bilateral hip replacements and a fractured left neck of femur, prior lacunar infarction, and a gastroesophageal reflux set of symptoms. He suffered a delirium following an influenza A infection that required inpatient rehabilitation, and he did initially present with a left upper limb Parkinsonian tremor but no other Parkinsonian symptoms or features. His regular medications included dabigatran, simvastatin, vitamin D and pantoprazole. He reported a family history of memory concerns, including his mother and maternal grandmother, and his great-aunt was formally diagnosed with dementia. With regards to his mood and psychology, he had occasional angry outbursts, but no depression or hallucinations, no delusions or paranoia. He was fully independent on assessment, and he was managing technology well. He did, however, struggle more with the recent tax return, and he has demonstrated other issues with planning. Generally, Eric was found to sleep well, have fluent language, had a steady non-Parkinsonian gait, and demonstrated no incontinence. 7 years prior to the assessment, he reported progressive cognitive changes, including forgetfulness, repetition, and misplacing objects. And in the 5 years prior to assessment, he uncharacteristically forgot the name of a niece. 2 years before assessment, he started repeating information, sometimes several times within a conversation, as well as forgetting the plot of TV shows. And he was also leaving doors, particularly of cupboards, open. Eric's wife reported concern for his declining memory and for his confusion, but she reported very little caregiver burden. On assessment, when I first saw him, he had a Montreal Cognitive Assessment score, a MoCA score of 27, and whilst this did fall within the normal range, it did reveal considerable short-term memory deficits. In fact, that's where he lost his 3 points. His MRI showed white matter ischemia, and bilaterally there was grade 2 on 4 hippocampal atrophy. Now, working as I do in conjunction with the Austin Hospital, I'm fortunate in being able to obtain amyloid PET scans where I feel that they are clinically indicated, and his was strongly positive for brain amyloid plaques, confirming that Alzheimer's disease was a significant and probably driving pathology. So, clinically, he had the diagnosis of mild cognitive impairment, and pathologically, this was due to Alzheimer's disease, although there may have been a vascular contribution, and there was a suspicion of Lewy body or alpha-synucleinopathy based on some of his symptoms, delirium, possibly early Parkinsonism, and we'll see how things unfolded there. This diagnosis was shared sensitively with Eric, emphasising that he was not yet in the dementia stage. Our goal was to push the dementia stage back as far as possible. So after his diagnosis, he started Souvenaid, a medical nutrition drunk for early Alzheimer's disease, and he was also referred to clinical trials at my site at the Austin. He received education on lifestyle changes, including provision of materials from Dementia Australia, and I also directed him to the Forward with Dementia, one word run together, Forward with Dementia website. After initial management strategies, he felt brighter and more alert, and a year later he was diagnosed with early Parkinson's disease by a neurologist and began levodopa therapy. He suffered a further episode of delirium after a cystoscopy for urge incontinence, with the cystoscopy demonstrating a benign bladder wall lesion, but the delirium again raising the suspicion of progression eventually to clear Lewy body disease as a co-pathology, as a co-diagnosis with Alzheimer's. He has since joined a clinical trial exploring the use of semaglutide or semaglutide for Alzheimer's disease, but this trial does allow people in with other pathology, including vascular pathology. He suffered some mild nausea while he first started taking the semaglutide, and this was managed with domperidone. Now, what about outcome? Well, 4 years on, when I most recently saw Eric, he remained independent and cognitively stable. His MoCA score stayed at 27 after 2 years, and then 26 after 4 years, and these scores still fall into the normal cognitive function category. He and his wife believe the combination of his care plan, including Souvenaid and participation in a clinical trial, has helped maintain his memory function and has given them a sense of agency over his diagnosis. Their satisfaction, and particularly his satisfaction with taking Souvenaid, has been considerable, and Eric plans to continue using Souvenaid indefinitely. Caregiver burden remains low, and both Eric and his wife feel empowered by this treatment plan. So, in conclusion, let's summarise with some key takeaways to consider for your practice. Firstly, early detection and accurate diagnosis of Alzheimer's disease, including in the mild cognitive impairment stage, and then a prompt management plan are key to supporting a patient's memory and function. Secondly, Souvenaid was well tolerated and the patient and carer ended up very satisfied with the medical drink, and Eric plans to continue to take it indefinitely. And thirdly, Souvenaid, combined with clinical trial participation in this case and supportive care, including emphasis on maintaining brain health, provided a sense of control and optimism for both the patient and the caregiver. Thanks for tuning in. This case, to me, and I hope to you, demonstrates how Souvenaid can form part of a comprehensive management plan for early Alzheimer's disease, and I hope that these insights help support you in your clinical practice, and also, of course, benefit your patients. Thank you.